Hello, and welcome back to Prevention Connection. In this part of our opioid series, we will be discussing medicated assisted treatment, otherwise known as MAT.
Hi there, I'm Dr. Matthew Beare with Clinica Vista. I'm our Medical Director of Special Populations, so I have interaction with our homeless, our substance use patients, and our migrant farm workers. MAT, in short, again, medication-assisted treatment, it's a treatment plan that falls outside of the very classic treatment for substance use disorder, especially opioid use disorder. A couple decades ago, things like methadone and Suboxone really came into favor, and what these are opioid replacements that are both coming from a safe prescriber and also have lower risk of the side effects of illicit opioids and those things associated with illicit opioid use. It's been absolutely transformational from both, my practice with my patients, but also seeing the changes in the lives of patients who have suffered from this illness and thought there was no real treatment prior to starting MAT. So there are two forms of, or two medications rather, to treat opioid use disorder. The more classic, or the original one that hit the market was methadone, and this hit the market, I believe, in the 70s and really gained favor in the 80s and 90s. And it is from a prescriber. It's in a safe setting. It is given out, dosed daily. It's a long-acting opioid, so you can have that dose one time a day, and that should get rid of the cravings, for a full 24 hours. The other medication that we use now is something called Suboxone, is a trade name. The generic is buprenorphine, and that can or cannot have another medication built into it. This medication has really grown in popularity in the last few years or so, and probably for good reason actually. But when it binds to the opioid receptors, it doesn't push the gas as heavily, which means you're not going to have the side effects that are associated with other opioids, such as the respiratory depression is the big one, right? That's the big one for all of us, is opioids kill people because when they take too much, it suppresses the drive to breathe. Suboxone doesn't do that. It doesn't get you high, for lack of better terms, which means that basically people can be on this medication and interact with others on a totally normal basis, not nod off, not feel like they're somewhere else. They can basically have normal interaction, which allows people to maintain relationships, to hold down jobs, and to interact with their peers as anyone else would. So the injectable form of naltrexone, Vivitrol is a trade name. It can actually be used for opioid use disorder as well. If you give someone who's suffering from opioid use disorder an injection of Vivitrol or naltrexone, basically any opioids that they use over the next month will have no effect because those receptors will be blocked. So it can be a deterrent, because then people who suffer from this disease sort of feel like, well, there's no point in me taking anything else because it's not going to do anything for me. There's sort of a misunderstanding, and there's this idea that we're trading one addiction for another, whereas if you're taking away, if you're getting off of illicit opioids and now you're putting in prescription opioids, well, isn't that the same thing? And absolutely not. It is not the same thing. It's very similar to treating a chronic illness. So saying people are addicted to their Suboxone is akin to saying diabetics are addicted to their insulin. And that's not the reality of addiction, and it's not the reality of chronic illness either.
Thanks for watching, and a special thank you to Dr. Beare and Clinica Vista. And be sure to subscribe to never miss a video.